Good afternoon and welcome to our Oncology lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends from across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Meghan Crawley. Her presentation is titled Oral Cavity Cancer and Reconstruction. Dr. Crawley is a head and neck surgical oncologist at Baptist Health Miami Cancer Institute who specializes in head and neck surgery and reconstruction. She has extensive experience in robotic surgery, surgical techniques, and facial nerve reanimation for patients who require reconstruction of facial functions. Dr. Crawley received her medical training at the University of Buffalo School of Medicine and Biomedical Sciences in Buffalo, New York. She completed a head and neck surgery residency at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania, followed by a fellowship in head and neck oncology and microvascular reconstructive surgery at Cleveland Clinic Foundation in Ohio. Upon completing her fellowship, Dr. Crawley joined Miami Cancer Institute. Her research has been featured in several peer-reviewed publications, including otorhinolaryngology, head and neck surgery, the laryngoscope, diabetes care, gastroenterology, and annals of otology, rhinology, and laryngology. In 2017, she was awarded the American Academy of Otorhinolaryngology Head and Neck Surgery Humanitarian Travel Grant for mission work in Haiti. During this medical mission trip, Dr. Crawley treated patients with advanced thyroid cancer and oral cavity tumors. Dr. Crawley's approach to patient care is to treat patients the way she would want herself and her family members to be treated. Having experience caring for loved ones with cancer, she understands the stress and anxiety that comes with diagnosing, treating, and the care that is required. She hopes to be a strong support for her patients and their families. Please let's give a warm welcome to Dr. Meghan Crawley. Dr. Crawley, thank you so much for accepting our invitation.
Yes, of course. Thank you so much for having me. Appreciate it. So I'll go ahead and share my screen.
Thank you.
Okay. So let me go here and just let me know if this is sharing.
We can see it, just maximize it.
Yes, let me go back. Started in the middle. All right, there we go. All right, very good. So yes, thank you so much for the lovely introduction. That was very nice. So my name is Meghan Crawley, gave you guys my background. So I have no disclosures. So learning objectives of this talk will be to go over oral cavity cancer subsites, give you a background on oral cavity treatment principles, and to summarize the brief history, fundamentals, and premise of oral cavity reconstruction, and then show you how we're using new technology to help with surgical planning and reconstruction today. So to go over, oral cavity cancer is actually a diverse collection of cancers. So it actually includes the mucosal lip, the buccal mucosa, the lower alveolar ridge, the upper alveolar ridge, the retromolar trigone, which is the area that meets between the two back teeth, two molars, the area between that and the gums, the floor of the mouth, which is under the tongue, the hard palate, and the anterior 2/3 of the tongue. If you're looking at the posterior portion of the tongue or the uvula or the soft palate or tonsils, that's classified as oral pharyngeal subsite. So this is everything anterior to that, which constitutes the oral cavity. Now, the pathology is quite diverse here. Oop, my screen just went black. Can anyone see me? Oh, 1 second.
We
Sorry.
can still see it.
Okay, good. Sorry, my computer just said is doing something funky. Whoop, 1 minute. Sorry about that. Okay, sorry about that. So there's a wide variety of pathologies that can present in the oral cavity. So this is by no means exhaustive. These are just things that I recently I've come across in the oral cavity this past month. But the list is very broad. The most common thing that we treat the most common malignancy in the oral cavity that we treat is squamous cell carcinoma. But we can also get pathologies of the salivary glands. So your mouth is covered in minor salivary glands. So anything that can affect the minor salivary glands can happen in the mouth. So that includes adenoid cystic, mucoepidermoid carcinoma, clear cell carcinoma, basal cell carcinoma, adenoid cystic, acinic cell. A very diverse amount of pathology can happen here. And then there's also benign pathologies that can exist there too, such as papillomas, pleomorphic adenomas, but this talk will focus more on cancer. So this picture is actually of a patient that presented to me. So these things can be kind of subtle. You know, this lesion is abutting her, it's her upper alveolar ridge and the buccal mucosa there. So this could be just the tip of the iceberg. So it's important that I'm looking out for on the exam, does she have sensory deficits, you know, any nasal congestion, infections, you know, is it involving deeper into the masticator space? Is it in the sinus? So these are all things that I'm mindful of when I'm evaluating a new patient. So it's important to obtain a history. So you need to identify risk factors. So the story is important. Did they happen to have just unexpected loose teeth? Did the teeth just fall out, no infection, no preceding issues, and then all of a sudden the teeth started falling out? I see that often. If people have a history of alcohol and tobacco use, those are risk factors to develop squamous cell carcinoma. Betel nut is a type of kind of a stimulant, and it's used usually in Asia, but betel nut can cause significant fibrosis and is a high risk factor for squamous cell carcinoma in the oral cavity as well. It's important to do a thorough physical exam. So this includes lifting the lips up and looking underneath the lips in the back, pulling the cheek over underneath, inspecting this gingival buccal sulcus. And I rely a lot on palpation. So sometimes you're not able to, you can have things that are submucosal. So if someone's complaining of pain, make sure you feel in that area, because you can especially sometimes feel things better than you can even see them. This is especially important for tongue exam. I've had many people where I can't see the tumor at all on their tongue, but I feel it, and I can feel that there's something very firm and unusual there, especially right in the corner where between the tongue and the lingual surface of the teeth. That's an area where you can get some ulcerative tumors, and it's easy to miss. It's also very important to inspect and palpate the neck. So take a feel for any lymphadenopathy, take a look for any lumps or bumps there, because oral cavity cancer does like to go to the lymph nodes. So these are the neck levels that we use to kind of define where things metastasize in the head and neck. So level 1A is a popular place for oral cavity cancer to go. It's between the anterior bellies of digastric here. Also level 1B, which is right around the submandibular gland. So we typically see a lot of metastases here and here. And then in level 2, which is right about here, and that's most commonly where you're going to see oral cavity cancer metastasize to, in the lymph nodes. You can check for 3 and 4. Less often do we see it in 5, which is behind your sternocleidomastoid here. But I take a good feel around everywhere, but I definitely focus up and around the chin and the angle of the mandible. So distant metastasis, this is something that you want to keep in mind for anyone with oral cavity cancer. So even if they have a small lesion, the workup should include looking at the lungs. So you want to make sure you get a chest CT, or if you have a PET scan available, it's very important to take a look at that. So, you know, on the left, this is a CT scan, which is showing a nodule on the right side. And then when they got a PET scan, this correlated with a PET avid lesion in the lung, which kind of helps us detect if there's cancer elsewhere in the body. Oral cavity staging is pretty unique. So this is from the AJCC 8 guidelines, which came out, I believe, in 2016. So the most recent updated guidelines. So TX is that the primary tumor cannot be assessed. Typically, we don't see this in oral cavity cancer. It's pretty clear where these are. TIS is carcinoma in situ, which we sometimes see with dysplastic lesions. You'll get some carcinoma in situ that hasn't broken through the basement membrane. T1 tumors are less than 2 centimeters. And then this is where it's new. The updated guidelines now include depth of invasion. I will go into the next slide defining what depth of invasion means. Depth of invasion is a significant predictor for metastasis. So if you have occult metastasis to the neck lymph nodes, and they found that if you have greater than 5 millimeters of depth of invasion, this is a significant risk factor. So that's why you get upstaged. Your tumor is upstaged based on depth of invasion alone in these new guidelines. So T1 is less than 2 centimeters, less than 5 millimeters depth of invasion. T2 is, again, less than 2 centimeters, and you have a depth of invasion that exceeds 5 millimeters, but less than a centimeter. Or the traditional staging, the tumor is between 2 to 4 centimeters, and your depth of invasion is less than a millimeter or centimeter. T3 is a tumor greater than 4 centimeters, or any tumor with a large depth of invasion, which is between 1 to 2 centimeters in depth. T4A is moderately advanced disease. So this invades adjacent structures or has a depth of invasion greater than 2 centimeters. And then T4B is typically, it's involving the masticator space, the pterygoid plates, the skull base, or in cases, the carotid artery. T4B is typically considered not resectable or extremely advanced disease. This is what I was talking about with depth of invasion. So oral cavity cancer can be both exophytic, meaning that it's bubbling up, or it can be endophytic, meaning that it is it's ulcerative. So how do you determine the depth of invasion? The depth of invasion is not the tumor thickness. This is very important, very different. The depth of invasion is the invasion, how deep does it go from the basement membrane? So the slide on the left, this is an example of an exophytic tumor. So the basement membrane is actually defined where that white line is. So the depth of invasion is much less than the tumor thickness in this case. So this is something that you would keep in mind when so this one maybe only has 3 to 4 millimeters of depth of invasion, although the tumor on the left side may be 6 millimeters in thickness. So it's important because that would change the staging in that case. The one on the right, this is an ulcerative lesion. And so the depth of invasion, they had to reconstruct the basement membrane. So because some of the tissue was eroded, they defined the basement membrane based on where it was on some normal tissue, and they dotted it across. So the depth of invasion is actually more than the tumor thickness in this case because of where they reconstructed the basement membrane. And again, this has implications for treatment and for staging. The oral cavity cancer staging, there's 2 types of staging for the nodal metastasis. So there's clinical staging, which is based on imaging and physical exam. So N0 is that you don't see any nodes clinically. Now, this doesn't mean that you wouldn't do a neck dissection. Sometimes we do neck dissections even in people that don't have clinically evident disease, because of that depth of invasion. If they have a large depth of invasion, typically if it's between 3 to 4 millimeters, it's recommended to get a neck dissection. Most places will recommend that, even if there's no overt signs of an enlarged lymph node. N1 will be if you see a lymph node that's 3 centimeters or smaller, so an enlarged lymph node. And on the imaging, you can't really appreciate extranodal extension, which means extranodal extension, meaning that the lymph node is not very well defined. It looks like it's breaking out of its borders or invading adjacent structures. This is kind of a marker for that it's breaking out of the lymph node. N2 is metastasis in a single node, and it's between 3 and 6 centimeters. And again, you don't have extranodal extension. N2B would be defined as multiple nodes on the same side as the tumor, less than 6 centimeters. N2C is bilateral or contralateral nodes, less than 6 centimeters. And again, no extranodal extension. In this case, if you see extranodal extension or it looks pretty obvious on exam or imaging, then you're looking at an N3 disease. Now there's pathologic staging. So pathologic staging is when you do a neck dissection and you remove the tissue, you get pathologic confirmation of the extranodal extension status. So they're going to look at the capsule lymph node to let you know if there's any cells that have broken free from that lymph node. So N0 would be that there's no disease in any lymph nodes. N1 is a single node on the same side as the tumor, less than 3 centimeters, no extranodal extension. N2A is going to be, again, single side, 1 node, less than 3 centimeters, but you do have extranodal extension. Or if you have a bigger node on the same side, 3 to 6 centimeters. N2B is going to be multiple nodes and there's no nodal extension. N2C is bilateral, or there's one on the opposite side. Again, no extranodal extension. N3A, you have a node that's greater than 6 centimeters. Somehow, though, there's no E&E, which is unlikely. And there's N3B, which basically is for a large node. So any node greater than 3 centimeters with extranodal extension, or if you have bilateral nodes and you have extranodal extension. So kind of complex there, but the big take homes for that are N1 disease. If there's no extranodal extension, it's a small node and there's only one. N2, if it's a small node but has extranodal extension, or if you have multiple nodes. And then N3 is pretty much if you have extranodal extension or an extremely large node. So the treatment for oral cavity cancer. So surgery is the main modality of treatment if it's resectable. Typically, oral cavity cancers don't completely respond to chemotherapy and radiation alone. It is possible to treat them, and I'm sure there are some successes, but as a whole, because the tongue is so dynamic and the oral cavity, it's hard to keep that very still. It's challenging to treat with just chemotherapy and radiation. Experimental therapies include immunotherapy. However, this is not the standard of care. Typically, this is reserved for people that are not candidates for chemotherapy or radiation. And the surgeries can involve significant morbidity, and reconstruction is a very important part of the treatment plan. So it's very important that you have a dental dentist on board, someone that can do prosthetics as an option, a head and neck reconstructive surgeon, a cancer ablation surgeon, radiation oncologist, medical oncologist, someone that's familiar with the radiology to help read the scans. These are all important parts of the team to help coordinate and make sure you get the best treatment plan. So I'm going to go switch now into the history of free flap reconstruction. So a lot of times for these treatments, you have to use a lot of techniques in order to restore the form and function. So free flap surgery or tissue transfer was actually developed, a lot of it was developed in World Wars I and II. So the way that they used to do this before they had micro instruments and microscopes was to do a technique called the waltzing pedicle. So what they would do is do stepwise transfer of surgery. So they would take tissue from let's say the shoulder, they would tube it, disconnect it, keep it attached on one end, wait for the new blood vessels to grow, then attach it and keep walking it up to where they needed the skin to grow. It was a very long, tedious process. But as you see, they were able to get some really remarkable results for that time period. So I just want to cover the reconstructive ladder. So this is what I'm considering when someone comes to me and they have an oral cavity cancer. What are our options for treatment? So the first one would be primary closure. And I'll show examples of all of these, but primary closure would be closing the tissue back together. So I remove a piece of tissue and then I just sew the edges together. That would be primary closure. Secondary intention. So I cut a wedge out and I just leave it open. I'm just going to let it granulate in, just heal on its own. And they'll probably have a defect there. It'll probably bleed. Not usually the best for oral cavity lesions. But although I do sometimes do that for maxillary defects with an obturator, that's sometimes a very good option. A skin graft, although it's really hard to get a skin graft to take in the oral cavity. Local tissue rearrangement, so you can do submental flaps, you can do FAM flaps, so taking cheek tissue and moving it around, or tissue from the hard palate to help reconstruct. Regional tissue, so this would be like taking a pec flap, so tissue from the chest and rotating it up. Or free flap tissue transfer, which is very dynamic. You can shape it in different ways, and I'll go into more of that. So what's the difference between a graft and a free flap? So I've been saying these kind of interchangeably. So a graft has no blood supply. So if I just take a free graft, like I take a piece of your rib and I just put it up there, it's not going to have any blood supply. It's going to use the blood supply from surrounding tissue. If you have a skin graft gets its blood supply from surrounding tissue. A flap has its own blood supply. So if it's a regional flap, I'm rotating up the blood vessels with the tissue, and it has blood attached to its original supply. If it's a free flap, I'm taking the artery and the vein from another location. So for example, the radial artery and vein from the wrist, I will take that artery and vein along with the tissue over it, and I will transfer that up into the head and neck, which requires me to sew the new anastomosis. So I sew it to the facial artery and the facial vein to create new blood supply to that tissue. So this is some examples of what I was talking about. So this is a primary example of primary closure. So this person had a lateral tongue defect. So we cut out a section of that tumor and then just sewed it closed. So just used interrupted vicral sutures to sew that part of the tongue closed. And people do very well with it. Secondary intention, you could use this for more superficial lesions. So something on the lip, like in this example, they resected this small lesion on the lip and they just let it heal in on its own, which heals very nicely in that area. This also can work for some gingival lesions. And like I said, some maxillary defects. If people choose to do an obturator, we let those heal by secondary intention. A skin graft is, again, most often I'm going to use that for primary closure. But the problem with the skin graft in the mouth is that you need something to apply pressure to the skin graft to get it to take. And it's not really feasible in the mouth. And then there's also significant contraction and scarring that can happen with a skin graft. So it's not typically my first choice. So you can do local adjacent tissues. So I mentioned this earlier. You can use cheek tissue. So from the cheek or the fat, you can rotate that over something called a FAM flap, which is using the facial, based on the facial artery, and you can move that tissue over to reconstruct oral cavity defects. You can use regional tissues. So like I mentioned, the pec flap. So using tissue from the chest and rotating it up, or you can take temporalis and rotate it down for some oral cavity defects. So free tissue transfer, when do I consider doing this? So there's some considerations that I take into account when I'm choosing what kind of free flap and if a free flap is necessary. I like to save some of the regional tissue transfers as a backup in the event that a free flap fails. So I like to use a free tissue transfer if I'm looking at a larger defect, because I think they have better outcomes and it's more cosmetically appealing than if I do rotational flaps. So some of the things when I'm considering what kind of flap to do is, do I need soft tissue? Do I need bone? How thick is what I'm replacing? So am I taking tongue? Am I taking cheek? Am I taking the floor of the mouth? Because that I would need something very thin versus a thigh, which most people have more fat. Then I'm going to need, thicker tissue. So the places that you can get free flaps, there's more than this, but there's the anterior lateral thigh, the radial and ulnar forearm. You can use the fibula to reconstruct the jaw, or the scapula. There's jejunal flap, but I don't typically use that. And there's also rectus flaps. These are also options. So I wanted to give an example. So this is a patient that I had, a 68-year-old male who had a squamous cell carcinoma of the right oral tongue, and it was ulcerative and it involved the floor of the mouth as well. So the planned resection was a hemiglossectomy, so taking half the tongue with portion of the mouth. So what I considered when I was considering our options for reconstruction, I wanted something that was thin because I'm taking the floor of the mouth, which is very thin, and you want something a little bit thin for the tongue as well. I wanted something that could move very easily, so when they were moving their tongue, they could still move that portion of tissue around. And then something that I was able to design the flap in a way that it would assist with function. So in this case, this gentleman, the one on the left is not my patient. The one on the right is their actual patient. I used a radial forearm free flap. So that was taking tissue from the wrist, so the radial artery and vein, and a portion of tissue from the wrist, and transferring it up into the mouth. So as you see, I took a portion of this gentleman's tongue on the right and sewed that in there. So another option is a local rearrangement. So sometimes we can take, especially for lip, you can just rotate some of the tissue around. So this one would be like an Abbe flap or an Abbe Estlander. So it's when you rotate the upper lip to reconstruct the lower lip. It does sometimes make the lip a little smaller, but it's a really good reconstructive option. So this is one of the ways, another case where this lady had a total maxillectomy. So the entire maxilla was removed. If we did not reconstruct that, her entire mid face would be sunken in, and she probably wouldn't be able to eat very well. We wouldn't really consider doing a obturator in this case, because there is nothing for the obturator to hang on to. So in this case, she had a fibula free flap. So they took the bone on the right that's all her leg bone. That's not her maxilla. And the little metal posts in there, we can put dental implants at the time of surgery so that they can get a full set of teeth after they heal. The middle picture is with the skin paddle in place. So the indent in there, that's actually her nasal septum. So that's why you see it kind of sucking up in there, is because her nose was exposed into her mouth. So she has that defect there. But the outcome comes out very nice. Like, she looks like a normal functioning human on the left. So some of the things that we do to help us plan these surgeries, especially if there's bone involvement, is that we do something called virtual surgical planning. So this is using patient data. So you can use a CT scan to help plan where you're going to make your cuts preoperatively. They make us guides so that we can just put that on at the time of surgery. And it probably cuts down at least an hour and a half to 2 hours off the surgery time to do this pre-op planning. And then what we also do, so we plan the cuts, they make us the cutting guides for the jaw, and then they translate that down into the leg to help us plan the segments that we can make to reconstruct a jaw or a maxilla with the fibula. So they make us a pre-guide to put on the fibula and the leg to make the pre-cuts as well. The ways that we can use this, we can use CT data. We can use mirror imaging. So let's say the tumor is too destructive and we can't anticipate what the jaw was supposed to look like. You can reflect the normal side to mirror that, or you can use normative data. So if someone has an extremely destructive tumor, or they have no normal landmarks yet, you can use normative data. So we can take data from other normal patients and extrapolate what they should have for a reconstruction based on that. This is another example. So these are the guides that I was telling you about. So the left side, that's kind of what the guide looks like. So the tumor would be in between those two cuts, and we just fit the guide right on there and make the cuts. And then they pre-bend a plate for us as well. So you put the reconstruction plate back on there, and then there's the cutting guide matches to the fibula so that we can make those segments that we need and then fit them in there. It's very nice. It really streamlines the surgery quite nicely. So in summary, head and neck reconstruction is a complex, it requires consideration not only of the aesthetic appearance, but you also really want to focus on function, because you want to make sure people can eat, drink, speak the best they can after surgery. Even small lesions may require extensive reconstruction. So like I said, this maxillary tumor looks like it's pretty, it's simple, but then when you get the imaging, it could be going into spaces that you didn't even dream of. So head and neck reconstruction is best completed in a multidisciplinary team. So you need head and neck surgeons, reconstructive surgeons, dentistry are all important to work together to help get the best outcome. So I just wanted to thank you all for listening, and I hope this was helpful.
That is quite impressive, Dr. Crawley. What a wonderful presentation. That was quite amazing. And I'm sure that the medical students will feel the same way, the ones that are listening today. Some of the cases that we receive are typically those lesions that dentists will identify, leukoplakias or linea alvis and so on, that they would say, this does not look kosher, does not look well. Go and see a maxillofacial surgeon. Once you get those cases, especially with the patients with leukoplakias, we know that that is pre-malignant. How often do you actually say, you know what, this is a malignant lesion, let me do something more to identify the pathology behind it?
So I think when in doubt, I think a good rule of thumb is when in doubt to biopsy. I think that there's little risk and distress associated with it. You're just taking a little sample. And I think that'll, at least give you the peace of mind. You can re-biopsy as many times as you need to. And I think that way you're not only, you're protecting yourself because you made sure that you did your due diligence, and B, you give some patients the peace of mind, but you also want to keep monitoring it and have frequent follow-up just to make sure. Right.
And in leukoplakias, for instance, if let's assume that it's nothing to be alarmed, how can you actually treat the lesion? Because obviously the patient tends to be anxious that there is something that is not necessarily well in his cheeks or his tongue.
So leukoplakia is challenging. So you can resect it. Sometimes it's really extensive. So I think there are some topical treatments that you can do. There's also laser treatments that you can do. But I think doing making sure that they're frequently followed up and they're definitely following someone is extremely important, because it can have a malignant transformation and you don't want someone to ignore something because they thought it was okay at that time.
Great. We have a question from Ana Pena, and she asks, what percentage of osteonecrosis do you have after treatment?
Oh, yes, osteonecrosis is a huge problem. As far as from surgery itself, not so much. It's when people have, I typically see it in people that got heavy doses of chemoradiation in the past. So when they had oral pharyngeal cancer, it's a big concern for our younger population, as we're getting more people getting oral pharyngeal cancer in their 40s, early 50s, and then they have to live another 40 years. We're seeing osteonecrosis in that population, or people that had radiation back in the 70s before we had IMRT or targeted radiation. We do see a lot of ORN, and that requires the virtual surgical planning and large resections and reconstruction. So as far as from our treatment, it's rare, but we definitely see it.
Mm-hmm. So there is, you said it's rare to treat it?
No, so it's treatable. So we try to do the least invasive things first. So I try to do prolonged IV antibiotics, maybe some local debridement, oral rinses, vitamin E, vitamin A, just trying to get that blood supply to be better. We can also do hyperbaric oxygen. That's also a possibility. And then sometimes it's just too advanced, the bone's entirely dead, and we have to resect it.
We have to resect and reconstruct that area. That's quite impressive. One of the other types of referrals that we get is typically from smokers that have developed some kind of an ulcer, especially in the tongue. And we're wondering, how frequent do you see this kind of cases where you have tongue ulcerations that are already malignant?
Oh, well, I get referred a lot of it. So I don't do general. So I'm not sure how often it is in the general population, but that's a large patient population for my practice. Is that
the bulk of the referrals?
The bulk, yeah, the bulk of what I see is squamous cell carcinoma, someone with a history of drinking, smoking, or something like that.
I see. So we're all going towards this new mode of treating patients and also training our docs to actually think preventively in order for us to tackle these conditions and make sure that we address them earlier in their stage. Any final words for our audience in regards to what they should really focus on that frustrates you as a maxillofacial surgeon, or a maxillo, you would tell the physician you should have identified this proactively in order for you to prevent this malignancy from advancing?
I think it's just important to do a thorough exam. I think it doesn't really come to the forefront of your mind to do a thorough oral exam and look in the mouth. Most people think, oh, dentists do that. Some dentists don't, they just focus on the teeth and they call it a day. So I think it's important as medical doctors as well to hone in on that and to also make sure you take a look in the mouth. I think that's important, and to listen to patients if they have pain or, persistent pain or something that's not healing. That's a big red flag. Something might look like, a canker sore, which fine, most things are, but if it doesn't heal in a couple weeks, make sure you keep following them up and you don't just brush it off. I think that's one of the things that a lot of people tend to do, is that they say, oh, I went to the dentist, they told me not to worry about it, and then they didn't biopsy it, and then here we are, and it's really advanced. Because once someone hears from someone, you're probably fine, a lot of times they won't challenge that. So I think it's important to keep in the back of your mind what's the worst case scenario, and to schedule regular follow-up.
Yeah, and also to keep in mind that not everybody goes to a dentist regularly for their checkup, so that would be also a plus to that. Well, you know what? I think that we have come to the conclusion of our conference since we do not have other questions. I think that this is absolutely brilliant. We love the fact that you have joined our team, and we love the fact that the interdisciplinary team at Miami Cancer Institute looks holistically at a case in order for you guys to come out with the appropriate treatment for the patient, which is our goal.
Yeah, absolutely.
Thank you so very much, Dr. Crawley,
Yeah,
for
my pleasure.
today. On behalf of our entire team at Baptist International, I would like to thank you once again, and to all of you for participating. I know that this is a subject that you're not accustomed to hearing or listening to, especially the students, but I know that you're curious. If you do have additional questions for Dr. Crawley, please make sure to send them to BHI webinar at baptisthealth.net. Let me repeat that, BHI webinars at baptisthealth.net. I promise I will forward that to Dr. Crawley for her response, and then we'll respond back to you. We look forward to seeing you all in our next oncology lecture series scheduled for October 6th, 2021. Thank you again. Stay safe and have a phenomenal afternoon. Thank you, Dr. Crawley.
Yes, thank you, everybody.